Welcome to the Deep Dive. We're the show where we grab a whole stack of fascinating sources, really dig into them, and pull out all the crucial insights to get you instantly up to speed. Today, we are plunging into a world that, honestly, for centuries, was just completely shrouded in mystery. A world where people, well, they mistakenly blamed bad air for these really debilitating fevers. We're talking about malaria. It's an ancient adversary, still one of humanity's biggest global health challenges. It affects millions, and as we'll see, it revealed some pretty surprising biological complexities. Our mission today: to take you on this incredible journey, really layer by layer, through this tiny but dangerous parasite. It's your shortcut to being well informed about one of humanity's oldest foes. We're going to explore its ancient origins, unravel its incredibly complex life cycle, which spans two different hosts, believe it or not, delve deep into its devastating impact on the human body, uncover the clever ways we actually detect it, and then unpack the multi-pronged strategies we use to fight it. And just when you think, okay, a mosquito-borne disease, how relevant is that elsewhere? Well, we'll review some unexpected and frankly crucial connections to other fields like dentistry. So get ready for some truly surprising facts, probably more than a few aha moments, and by the end, you'll have a much deeper understanding of why malaria remains such a persistent, such a challenging problem worldwide. Okay, let's unpack this right from the very beginning. The name itself, malaria. It's quite evocative, almost poetic, isn't it? But it hides a pretty dark and fascinating history. Where does that name even come from?
It absolutely does. The name malaria, it's actually derived straight from Italian. The phrase malaria.
Malaria.
Which literally translates to bad air.
Bad air. Wow.
Yeah. And what's fascinating here is how the name itself, it just encapsulates centuries of human misunderstanding, really. Early attempts to explain these widespread fevers before we had the scientific tools to understand the real culprit. For a very, very long time, people observed that these terrible fevers, they were intimately linked to swampy areas, marshlands, damp environment.
Right, places with stagnant water.
Exactly. So they attributed the illness to, noxious fumes or bad air rising from these places. They thought inhaling these miasmas was the source of the affliction.
Makes a certain kind of sense if you don't know about microbes.
It does. So the name malaria is a direct kind of linguistic fossil of that historical misconception. A time when the true cause, this microscopic parasite transmitted by mosquitoes, was just utterly unknown to science.
So for centuries, it was this invisible atmospheric threat, bad air. But in reality, as we now know, it's a microscopic enemy, very specific. And despite all our advancements, it's still a massive global problem, isn't it?
Precisely. Despite everything we've learned, all the monumental efforts poured into trying to eradicate it, malaria remains an incredibly important cause of fever and, sadly, mortality. It's especially prevalent in tropical and subtropical areas all around the world.
The scale is just hard to grasp sometimes.
It really is. The sheer scale of its impact is staggering. According to the World Health Organization, we're talking hundreds of millions of cases every year.
Hundreds of millions?
Yes, leading to hundreds of thousands of deaths. And these are primarily among young children, under 5, and pregnant women, especially in sub-Saharan Africa. It's a disease that continues to place this immense, crushing burden on healthcare systems, on economies, and of course on individual lives in endemic regions. It really perpetuates cycles of poverty and ill health.
And the real culprit, as you mentioned, isn't some invisible gas. It's something living, microscopic. Can you introduce us to this hidden enemy?
That's right. The actual cause isn't a bacterium. It's not a virus. It's protozoan parasites. They belong to the genus Plasmodium.
Plasmodium, okay.
These are fascinating single-celled eukaryotic organisms, which means, unlike bacteria, they have a complex internal structure, including a nucleus. They're distinctly different from bacteria or viruses, which dictates, very different approaches to treatment and prevention. These particular parasites belong to a specialized group called Apicomplexa.
Apicomplexa. What does that mean?
Yeah, it raises an important question. What exactly is an apicomplexan? And what makes a parasitic infection like malaria distinct from, say, a bacterial or viral one? It's a fundamental difference that really dictates how the disease progresses and how we fight it. So an apicomplexan parasite, like Plasmodium, it's unique because it possesses this distinct structure at one end, what scientists call an apical complex.
Apical complex, like a tool.
You can almost imagine it like a microscopic grappling hook, or maybe a specialized drill. This complex allows them to effectively penetrate and invade host cells like our liver cells or red blood cells, and that's absolutely critical for their survival and their ability to cause disease. Unlike bacteria, which often replicate outside cells, or viruses, which kind of hijack the cell's machinery, Plasmodium is what we call an obligate intracellular parasite for much of its life cycle.
Meaning it has to live inside our cells.
Exactly. It must live inside our cells to survive and multiply. And this intracellular lifestyle, well, it makes them harder for our immune system to find and harder for drugs to reach. It presents a really unique challenge in treatment.
So a highly specialized single-celled organism with its own invasion toolkit. And within that Plasmodium genus, it's not just one type causing all the trouble, is it? There are a few main players.
Indeed. While there are actually numerous species of Plasmodium, 4 are primarily responsible for the vast majority of human malaria cases.
Okay, the big 4.
The big 4 are Plasmodium falciparum, Plasmodium vivax, Plasmodium malaria, and Plasmodium ovale. Now, each of these species can cause malaria, but their characteristics, the severity of the illness they cause, even their geographical distribution, they vary quite a bit.
And one is much worse than the others.
Yes. The Plasmodium falciparum is by far the most dangerous. It's notorious for causing the most severe and often fatal form of the disease. It's responsible for the vast majority of malaria-related deaths globally.
Wow. And the others, like Vivax.
T. vivax, well, it's less often fatal, thankfully. But it's notable for something else, its ability to cause relapses, months or even years after the initial infection. That's a challenge we'll definitely delve into shortly.
Okay, so we have these incredibly cunning Plasmodium parasites, single-celled organisms using their apical complex to invade, but their life cycle.
Okay.
It's not simple at all, is it? It's incredibly intricate. A real masterpiece of parasitic evolution involving not one, but 2 different hosts, which is a key part of what makes malaria so difficult to tackle.
Absolutely. It truly is a masterclass in parasitic strategy and adaptation. The Plasmodium parasite requires 2 distinct hosts to complete its complex life cycle. Humans, we serve as what's called the intermediate host.
Intermediate host, that's where the disease happens.
That's right. This is where the parasite undergoes asexual reproduction, multiplying rapidly, and that leads directly to the clinical disease symptoms we see and feel.
Okay, and the second host.
The other crucial host is the mosquito. Specifically, the female Anopheles mosquito. They are the definitive host.
Definitive host. What happens there?
That's where the sexual reproduction of the parasite takes place. Without both hosts, human and mosquito, the parasite simply cannot complete its full life cycle. It can't perpetuate itself.
It's almost like a 2-act play, isn't it, with different essential parts happening in different homes. So how does the curtain rise on this play? How do we, humans, actually get infected and become the unwitting first stage of this parasitic drama?
The route of infection is what we call vector-borne, meaning it's transmitted by an intermediary, in this case, the bite of an infected female Anopheles mosquito.
Only the females bite.
Only the females need the blood meal for their eggs. So, when an infected female mosquito bites a human, it injects a highly specialized infective form of the parasite. These are called sporozoites.
Sporozoid.
Right? It injects them directly into our bloodstream from its salivary glands. These sporozoites are incredibly efficient. They're basically designed for one purpose, to swiftly reach their first human target. This injection of sporozoites is the starting point, the opening scene of the human infection.
Okay, so these tiny invaders get injected. Where do they go first? They don't just start attacking red blood cells straight away, do they? I think that's what malaria did.
That's a common thought, but no. There's an important stop-off point first. The initial critical sites of infection in humans are first the liver, and then subsequently the red blood cells, or RBCs.
The liver first.
Yes. It's a precisely choreographed invasion, almost like a carefully planned military operation by the parasite.
Okay, let's talk about that initial stage then. The human saga, starting in the liver. What happens there? You said we're often completely unaware of the invasion at this point.
That's right. This is what we call the liver stage, or technically the exoerythrocytic cycle.
Exo meaning outside.
Exactly. Outside the red blood cells. So when that infected mosquito bites and injects those sporozoites, they don't hang around in the bloodstream for long. They rapidly travel through the bloodstream and invade liver cells' hepatocytes.
How fast?
This journey to the liver can take as little as 30 minutes.
Wow.
Once inside these liver cells, the sporozoites undergo this dramatic transformation. They start multiplying asexually, silently, for about 5 to 14 days, depending on the species.
Yeah.
They form these large structures called hepatic schizons.
Hepatic meaning liver, schizons. Are those the multiplying parasites?
Essentially, yes. Each schizont can contain thousands of new, genetically identical parasites called merozoites.
Thousands from one sporozoite.
Potentially, yes. Thousands. Eventually, the infected liver cells just rupture. It's like a silent explosion, releasing all these newly formed merozoites into the bloodstream. And this stage is absolutely crucial because it's largely asymptomatic.
No symptoms at all?
Generally, no. The parasite is basically setting up shop without the host knowing it. You don't feel sick at this point, which makes early detection in this phase nearly impossible without specialized screening. And here's where it gets really fascinating.
Relapse.
Exactly. For these species, some of those sporozoites, once they enter the liver, they don't immediately develop into schizons. Instead, they can transform into these dormant forms called hypnozoites.
Hypnozoites. Like sleeping forms.
Precisely. Think of them as silent, ticking time bombs, lying latent in the liver cells for months or even years.
Years.
Yes. These hypnozoites can reactivate later, develop into merozoites, and burst forth, causing a relapse of the disease even without a new mosquito bite.
That's incredible. So someone could think they're cured.
Exactly. Someone who traveled to a malaria area, got treated, seemed cured, but then gets sick again long after they've returned home, sometimes years later. It perplexes patients and uninformed clinicians alike. It's a huge clinical and epidemiological challenge for these specific species, making eradication efforts much, much more complicated.
Wow, so the parasite has this incredibly sophisticated way of hiding out, like a ticking time bomb. And once those merozoites are finally released from the liver, either immediately or after dormancy, that's when things really kick off. That's when the debilitating symptoms start to emerge, the blood stage.
Exactly. That's the blood stage, or the erythrocytic cycle. And this is truly where the classic debilitating symptoms of malaria finally emerge. Merozoites released from the liver are highly specialized to invade red blood cells.
Okay, now we're in the blood.
Right. Once inside the RBCs, they undergo further rapid asexual development and replication. They pass through distinct morphological stages. First, they appear as what we call trophozoites, often seen under a microscope as these tiny, delicate ring forms inside the red blood cell.
Like miniature engagement rings?
Kind of, yeah. These trophozoites then feed on the red blood cell's hemoglobin and mature into larger forms called schizons. These are essentially sacs containing multiple new merozoites, sometimes dozens of them packed inside one red blood cell.
So they're just multiplying like crazy inside our own red blood cells. That sounds incredibly efficient for the parasite, but incredibly destructive for us. This repeated rupture of our own red blood cells, that is what causes those classic symptoms, isn't it? The chills, the fevers, the sheer exhaustion. It's a direct assault on our blood.
That's spot on. The infected RBCs become increasingly fragile and then they rupture, often in a synchronized manner every 48 or 72 hours, depending on the Plasmodium species.
Synchronized?
It's not perfectly understood, but it seems they coordinate their development cycle. This explosion releases a whole new generation of merozoites, which then immediately go on to infect new healthy RBCs. And this cyclical rupture happening across potentially millions or even billions of cells simultaneously leads to an exponential rise in parasitemia, more and more parasites in the blood. It's this precise, synchronized process that directly causes the clinical illness and those characteristic paroxysms of fever and chills.
You can almost set your watch by it sometimes.
You literally can, with some species. The fevers return predictably,
Yeah.
linked directly to this mass cellular destruction and the release of parasite material and toxins into the bloodstream. And here's another critical part of the blood stage, a really brilliant evolutionary twist. Some merozoites, instead of just continuing this asexual replication cycle to cause more disease, they take a different path.
A strategic move.
Very strategic. They develop into sexual forms called gametocytes. There are male microgametocytes and female macrogametocytes, all still contained within red blood cells.
Okay, male and female forms. What do they do in humans?
In humans, nothing, really. They don't cause symptoms, and they can't replicate further in us. But they are absolutely essential for the parasite's survival and its ability to spread.
Ah, so this is for the next stage, the mosquito.
Precisely. If we connect this to the bigger picture, the formation of gametocytes is this sophisticated evolutionary strategy. It's the parasite's way of preparing itself for the next leg of its journey. It ensures genetic exchange, survival, genetic diversity, and transmission to a new host, the mosquito. It completes the life cycle and perpetuates the disease in the population. Without these gametocytes, the cycle breaks.
So we, the human host, are not only suffering the disease, but also unwittingly producing the crucial next generation for the parasite. But that's only half the story, right? The mosquito plays an equally vital, fascinating role in completing this incredibly complex transmission chain. How does the parasite get from us back into the mosquito, and what happens then?
Indeed. This brings us to the mosquito stages, also known as the sporogonic cycle. It's a truly ingenious final act. When an Anopheles mosquito takes a blood meal from an infected human, it ingests those circulating gametocytes we just discussed, along with the human blood.
So it sucks up the male and female forms.
Exactly. Inside the mosquito's gut, this remarkable transformation occurs. These male and female gametocytes mature and undergo sexual reproduction, a unique event for a single-celled organism happening inside the mosquito. They form a motile, worm-like stage called an ookinet.
Ookinet, like a little moving thing.
Yeah, imagine a tiny, active larva, almost like a microscopic grub, moving purposefully. These ookinets then burrow through the mosquito's gut wall and develop into oocysts. These are essentially quiet, growing cysts on the outer surface of the mosquito's midgut.
Cysts on the outside of the gut.
Right. These oocysts grow and mature over about 10 to 14 days, and eventually they rupture, releasing thousands of new sporozoites.
Sporozoites, the same things that started the human infection.
The very same infective forms. These sporozoites then migrate from the gut cavity through the mosquito's body, making their way specifically to the mosquito's salivary glands.
Ready for the next bite.
At this point, the mosquito is now fully infectious, ready to transmit the parasite to the next human it bites, starting the entire cycle all over again. It's just a marvel of parasitic evolution, isn't it?
It really is.
A perfectly orchestrated two-part cycle allowing the parasite to thrive across completely different environments.
Yeah.
And understanding every single step of this journey, every link in this chain, is absolutely vital for disrupting transmission and developing effective interventions. If you can break any link in the human or the mosquito, you can potentially stop the spread.
Okay, so we have this incredibly complex two-host life cycle, perfected over millennia by Plasmodium. Now let's really focus on what happens when that cycle plays out inside a human body. The pathogenesis, the way it actually causes disease, is quite profound, isn't it? Leading to this long, persistent illness, symptoms fluctuating dramatically.
It is indeed. Malaria is typically characterized by a long, persistent disease. The symptoms frequently fluctuate in intensity, coming and going in those classic cyclic patterns we touched on.
The fevers and chills.
Exactly. The hallmark symptoms are precisely those. Recurrent paroxysms of fever and chills, often accompanied by headaches, muscle aches, nausea, vomiting, and just profound fatigue. Now, these symptoms are primarily due to two interconnected factors. First, the host's vigorous inflammatory response to the invading parasite. And second, critically, that synchronized rupture of infected red blood cells we talked about.
So the rupture itself triggers the symptoms.
Largely, yes. When potentially billions of red blood cells rupture almost simultaneously, releasing parasites, parasite waste products, hemoglobin, cellular debris into the bloodstream, it triggers this massive systemic immune reaction. That causes the sudden onset of intense chills, followed by a rapidly rising, often very high, fever, and then usually drenching sweats as the fever breaks. But the effects extend far wider than just fever and chills. The extensive hemolysis, the destruction of red blood cells, directly leads to varying degrees of anemia.
Anemia, lack of red blood cells.
Right, which can range from mild to severe and life-threatening. Anemia, in turn, impacts the body's oxygen-carrying capacity. That leads to fatigue, breathlessness, dizziness, and potentially organ dysfunction if it's severe enough. Furthermore, the widespread blockage of capillaries by infected red blood cells, which we'll discuss more with falciparum, can lead to organ hypoperfusion.
Hypoperfusion, less blood flow.
It's exactly.
Reduced blood flow.
And ultimately ischemia, where tissues are literally starved of vital oxygen and nutrients. Depending on the Plasmodium species and the severity, this hypoperfusion can cascade into serious organ damage. Things like splenic rupture, which can be fatal, and cardiac, renal, kidney, and pulmonary lung failure.
And this connects to our listeners in dentistry too, right? Someone with severe anemia or organ issues.
Absolutely. A patient presenting to a dental office with severe anemia might have increased bleeding risk during procedures or impaired healing. Compromised kidney or liver function could affect how they handle dental medications or anesthesia. It underlines why a thorough medical history is so vital in any healthcare setting.
Now, you mentioned different species have different characteristics. You singled out Plasmodium falciparum earlier as the absolute worst. What makes it so uniquely dangerous compared to the others?
Yes, unequivocally, P. falciparum. It is notorious for causing the most severe and unfortunately often the most fatal form of malaria. Its unique danger lies primarily in its aggressive ability to drastically alter the membrane of the red blood cells it infects.
How does it alter them?
It inserts parasite proteins onto the surface, making these infected RBCs incredibly sticky. This process is known as cytoadherence.
Sticky red blood cells. That sounds bad.
It's incredibly bad. This stickiness causes the infected red blood cells to adhere to the lining of small blood vessels, the capillaries and venules, particularly in vital organs. Instead of flowing freely through the circulation, they just clog up the works.
So they block the tiny blood vessels.
Exactly. This leads to a devastating cascade of problems. Widespread hypoxia, severe oxygen deprivation in the surrounding tissues, outright blockage of capillaries, literally cutting off blood supply to vital organs like the brain, kidneys, lungs. And it triggers a profound, widespread inflammatory response throughout the body as the immune system tries, often futilely, to clear these blocked vessels.
So what does this all mean for someone infected with falciparum? It sounds much more aggressive, like it's causing a systemic shutdown almost.
It absolutely is. P. falciparum infections typically exhibit significantly higher levels of parasitemia,
meaning way more parasites in the blood.
Far more red blood cells are infected compared to other species, often reaching levels where 10%, 20%, or even more of the red blood cells are infected. This amplifies the damage exponentially. The extensive cytoadherence and this high parasite burden can result in what looks like septicemic malaria, a severe systemic inflammatory response resembling bacterial sepsis and even circulatory collapse or shock. And a particularly gruesome, often fatal complication specific to severe P. falciparum is something called blackwater fever.
Blackwater fever?
Yes. It's characterized by extensive, incredibly rapid red blood cell destruction. So much hemoglobin is released into the bloodstream that the kidneys can't handle it, and it spills into the urine, giving it a distinctive dark red to almost black color. It's a terrifying sign of severe uncontrolled hemolysis and acute kidney injury, often fatal.
That sounds absolutely horrific. Beyond falciparum's specific dangers, what are the overall devastating complications of malaria that medical professionals, including dentists, need to be aware of, even if they aren't infectious disease specialists?
The complications can indeed be devastating and affect multiple organ systems. As we touched upon, severe anemia is a direct and very common consequence, sometimes requiring urgent blood transfusions. The vital organs, the liver, kidneys, lungs, are particularly susceptible to damage and failure. This can be due to hypoperfusion from blocked capillaries, direct parasite effects, or the overwhelming inflammatory response. Acute kidney injury requiring dialysis, liver failure, acute respiratory distress syndrome, ARDS. These are all serious possibilities.
And in the brain, you mentioned blockage there too.
Yes. One of the most severe and feared complications is cerebral malaria. This occurs primarily with P. falciparum. The parasite-infected red blood cells sequester or stick in the capillaries of the brain,
blocking blood flow to the brain.
Exactly. This cuts off oxygen and nutrients, causes inflammation, and can lead to life-threatening conditions like seizures, profound coma, and even permanent neurological damage like cognitive impairment or epilepsy for those who survive. This really highlights the devastating potential of malaria, particularly for those vulnerable populations. Children under 5 whose immune systems aren't fully developed, pregnant women, and individuals with any kind of immunosuppression, like those with HIV/AIDS. Access to immediate, effective treatment is critical and often lacking in precisely the places malaria hits hardest. It's a disease that can literally shut down multiple organ systems.
And again, for a dental professional, recognizing signs may be confusion, unusual sleepiness, jaundice indicating liver problems, shortness of breath in a patient, even if they came in for a toothache, could be critical for getting them urgent medical attention.
Absolutely crucial. That holistic view is key.
The body's immune system usually helps us fight off invaders. But with malaria, it seems like it can sometimes be a double-edged sword, paradoxically contributing to the problem. And then there are these truly surprising, almost mysterious links to other diseases, particularly a type of cancer.
You've hit on a critical and really complex point. While our immune system is, of course, trying desperately to clear the Plasmodium parasites, their very presence can trigger an exaggerated or dysregulated response. They stimulate immune cells, like macrophages, to release these potent inflammatory signaling molecules called cytokines, things like interleukin-1, IL-1, interleukin-6, IL-6, and tumor necrosis factor alpha.
Those sound familiar from inflammation generally.
They are. And while these cytokines are initially part of the body's natural defense, an overactive or prolonged inflammatory response can paradoxically contribute significantly to the pathology and the severe disease we see in malaria. It's not just helpful inflammation. It can become a runaway immune train, a systemic cytokine storm that can be as damaging or even more damaging than the parasite itself. Your own body's defenses effectively turn against healthy tissues.
So the parasite kind of weaponizes our own immune system.
In a sense, yes. It's a cruel paradox the parasite has learned to exploit. Malaria can also result in something called immune complex-mediated hypersensitivity. Antibodies bind to parasite antigens, form these complexes, and they deposit in tissues like the kidneys, causing further inflammation and damage. Now, for that truly surprising link you mentioned, there's a notable, well-documented association between endemic malaria, particularly chronic or repeated infections, and Burkitt's lymphoma.
Burkitt's lymphoma, that's a cancer.
Yes, a highly malignant B-cell tumor. It's particularly prevalent in children in malaria endemic regions of Africa. What's fascinating here is this incredibly complex interplay between different pathogens and the host immune system. It's a remarkable example of how environmental factors can converge to create a specific vulnerability.
So malaria causes this cancer?
Importantly, no. Plasmodium itself does not directly cause the malignant tumor. The theory is more nuanced.
Okay, how does it work then?
It's theorized that the chronic presence of the malarial parasite and its profound influence on the reticuloendothelial system.
What system?
The reticuloendothelial system is basically the body's vast network of specialized immune cells, like macrophages and lymphocytes, responsible for clearing debris and fighting infection throughout the body, especially active in the spleen, lymph nodes, liver.
Okay, the body's cleanup and defense crew.
Right. Chronic malaria puts this system into overdrive. This sustained abnormal immune stimulation might then predispose individuals to a more aggressive or malignant response to another common virus, the Epstein-Barr virus, or EBV.
EBV, the monovirus.
Exactly. EBV is ubiquitous. Most people get it. But in the context of this altered immune landscape created by chronic malaria, EBV infection might be more likely to trigger the malignant transformation of lymphoid tissue, leading to Burkitt's lymphoma.
Here's where it truly gets mind-bending. A disease spread by a mosquito bite could indirectly, through messing with the immune system, make someone more vulnerable to a cancer caused by a completely different virus. That's a huge aha moment. Incredibly unexpected.
It really underscores how interconnected things are.
Yeah. It shows how one infection can, in this complex way, pave the way for another even more serious condition. And for our dental professional listeners, you mentioned Burkitt's lymphoma often shows up in the jaw.
Precisely. It's not a direct cause, but a significant predisposing factor that changes the immunological landscape. And yes, Burkitt's lymphoma frequently presents with characteristic rapid swelling or tumors in the jaw or face. It can loosen teeth, cause facial asymmetry. A dentist might genuinely be the very first healthcare professional to spot such a growth. Recognizing it, even if just as something abnormal needing urgent investigation, could trigger the referral cascade leading to diagnosis and potentially life-saving cancer treatment. It again highlights that indispensable role of comprehensive medical knowledge, even for specialists focused on one area like the mouth.
Okay, so given all this complexity, the different species, the potential for severe complications, how do medical professionals actually diagnose malaria? You can't just feel sick and know it's malaria, especially with those vague early symptoms. There must be a specific, reliable way to detect this hidden enemy.
Indeed. Definitive diagnosis relies on laboratory tests, and the gold standard, even today, remains microscopic examination.
Looking under a microscope. Still
the gold standard. The primary specimen is blood, usually obtained via a simple finger prick or sometimes a vein draw. Specifically, microscopy of stained peripheral blood films is considered the gold standard because it allows for direct visualization of the parasite itself. You can literally see it. Within this, there are two main complementary techniques using these blood films or smears, the thick blood smear and the thin blood smear.
Thick and thin, what's the difference?
The thick smear is prepared by spreading a larger drop of blood over a small area on a glass slide, then staining it. This technique concentrates the blood cells, lysing the red cells, but leaving the parasites. It's primarily used to detect the presence of parasites, and to quantify parasitemia, estimate how many parasites are present per volume of blood. Because it concentrates things, it's very effective at spotting even low levels of parasites, highly sensitive for initial detection.
Okay, so thick smear finds if it's there. What about the thin smear?
The thin smear is prepared differently, spreading a very thin layer of blood, ideally just one cell thick, allowing the red blood cells to remain distinct and separated. This is crucial for species identification and for assessing the morphology, the shape and appearance of the parasites. It preserves the red blood cell and parasite shapes much more clearly.
So you need both.
Ideally, yes. Thick for detection and density, thin for species ID and detail. Now, why is microscopy still considered the gold standard, even with all the advanced diagnostic tech we have now?
Yeah, why?
It's because it offers that direct visualization. It allows for differentiation of the various life stages you might see in the blood rings, trophozoites, gazons, kometocytes, and critically, it enables the precise quantification of parasite density, which is vital not just for the initial diagnosis, but also for monitoring how well a patient is responding to treatment. You can literally see the invaders and count them, and watch their numbers decrease with effective therapy.
So even in this high-tech age, sometimes the oldest methods are still the most reliable because you're directly seeing the culprit. But are there other methods beyond just looking through a microscope, maybe for quicker results or in places where good microscopy isn't available?
Yes, absolutely. Beyond conventional microscopy, several other diagnostic methods are widely used. There's also QBC, or quantitative Buffy code.
QBC.
Yeah, it's another microscopic method, but slightly different. You collect blood in a specialized capillary tube coated with acridine orange dye. When you centrifuge it, the blood separates into layers. The parasites, stained by the dye, concentrate in the buffy coat layer between the red cells and plasma, making them easier to spot under a fluorescent microscope. It's a rapid method, often used for screening. Then we have serological methods, primarily rapid diagnostic tests, or RDTs, and ELISA, the enzyme-linked immunosorbent assay.
RDTs, those sound useful.
They are incredibly useful. These are quick tests, often looking like a pregnancy test strip. They don't necessarily require a microscope or highly trained personnel for an initial result, usually within 15-20 minutes. They work by detecting specific parasite antigens, proteins from the parasite, or sometimes antibodies your body makes against the parasite in a drop of blood.
So they detect parasite parts, not the whole parasite.
Exactly. RDTs are particularly invaluable in remote or resource-limited settings where good microscopy just isn't available. They provide fast answers to guide immediate treatment decisions.
And for really subtle infections, or confirming the species.
For that, we turn to molecular methods. PCR, polymerase chain reaction.
PCR. We hear about that a lot now.
We do. It's a highly sensitive method that can detect even tiny fragments of the parasite's DNA. It acts like a molecular magnifying glass, amplifying minute quantities of genetic material millions of times over. PCR is especially useful for diagnosing very low-level infections, where parasites might be too few to see reliably under a microscope, or for definitively differentiating between species when the morphology on the smear is ambiguous. It can also detect drug resistance genes.
Okay, so a whole toolkit of diagnostic options. Imagine being that laboratory scientist, though, peering down a microscope, trying to tell these species apart. It must take an incredibly trained eye to spot those subtle but critical differences, right?
It absolutely does. Malaria diagnosticians undergo extensive training. It's a real skill. They look for very specific morphological characteristics that distinguish one species from another.
Like what? What are they looking for?
Well, for instance, P. falciparum. It's known for often having multiple tiny ring forms inside a single red blood cell. Sometimes you see applique forms stuck right on the edge. You might also see distinct reddish, comma-shaped markings called Mohr's dots or clefts within the infected red cells. Those are unique markers. And, of course, its characteristic crescent-shaped gametocytes are unmistakable if they're present.
Crescents?
Yes, banana or crescent-shaped. Very distinct for falciparum. Now, P. vivax, in contrast, typically causes the infected red blood cells to enlarge significantly, become quite pale. And you'll often see the presence of fine, pinkish, stippled dots called Schuffner's dots covering the surface of the infected RBC. The parasite stages themselves also tend to look more amoeboid, less compact than falciparum.
So bigger cells, different dots. What about the others?
P. malaria often affects older, normal-sized red blood cells. It can present with distinctive band forms where the parasite stretches across the cell, or you might see Zeeman stippling, which are very fine dots, hard to see. Its cycle is 72 hours compared to 48 for the others, which can sometimes be inferred. And P. ovale is similar in some ways to P. vivax. It also causes enlarged red blood cells, often with fringed or jagged edges, giving them an oval shape, hence the name. And it also displays Schuffner's dots, often coarser than in vivax. These microscopic distinctions are incredibly vital. They guide treatment choices, because different species respond differently to specific drugs, and they predict the clinical course, like the risk of severe disease with falciparum or relapse with vivax and ovale. Accurate identification is absolutely paramount for effective patient care.
Okay, so we've identified the enemy, we understand its complex journey, we know how we diagnose it. Now, how do we fight back? What does the current treatment landscape for malaria actually look like? It sounds like we must have a decent number of tools in the arsenal by now.
We do have a range of effective anti-malarial drugs. The choice depends heavily on the specific Plasmodium species identified, the severity of the illness, and crucially, the geographical region where the infection was likely acquired, because of varying patterns of drug resistance. Chloroquine for decades was the primary drug of choice, a real workhorse, cheap and effective. But unfortunately, resistance to it, especially by P. falciparum, is now widespread in many parts of the world, limiting its use significantly.
So chloroquine is often out now.
In many areas for falciparum, yes. Quinine, one of the oldest antimalarials, derived from cinchona bark, remains a powerful option. It's frequently used, often intravenously, for severe malaria, sometimes in conjunction with other drugs like doxycycline or clindamycin, especially when resistance to other drugs is suspected. Beyond those, we have a range of other important antimalarials targeting different stages or pathways. There's Fansidar, a combination of sulfadoxine and pyrimethamine, though resistance is also an issue there. There's Primaquine.
Primaquine, you mentioned that for the sleeping forms.
Exactly. Primaquine is essential for treating the dormant hypnozoite forms of P. vabrax and P. ovale hiding in the liver. It's the only widely available drug that reliably clears them and prevents relapse, but it requires careful screening beforehand, as it can cause problems in people with a specific enzyme deficiency called G6PD deficiency. Then there's halofantrine, mefloquine, and critically, the artemisinin-based combination therapies, or ACTs.
ACTs, those sound important.
They are the cornerstone now. Artemisinin derivatives, originally isolated from a Chinese herb, are incredibly potent and act very rapidly against the parasite. They're now the frontline treatment for uncomplicated P. falciparum malaria in almost all endemic areas. They're always given in combination with a longer-acting partner drug like lumefantrine, amodiaquine, poparaquine, or mefloquine to protect the artemisinin component from developing resistance too quickly.
So always a combo therapy.
Yes, that's the standard. We also have modern fixed-dose combinations like atovaquone proguanil, often known by its brand name, Malarone. It's commonly used for prophylaxis or prevention in travelers, and sometimes for treatment too. But while we have these powerful drugs, we face huge challenges. You asked about resistance.
Yeah, is resistance still a major problem?
It is a constant evolving threat. It's an evolutionary arms race. The Plasmodium parasite continually develops new genetic mutations that allow it to survive our treatments. Resistance has emerged to almost every antimalarial drug we've developed, including worrying signs of emerging resistance even to artemisinins in Southeast Asia. This forces scientists to constantly monitor resistance patterns, develop new drug combinations, or search for entirely new drug classes with different mechanisms of action.
And getting the drugs to people.
That's the other massive challenge. Ensuring these life-saving drugs actually reach every person who needs them, especially in remote or underserved areas with weak healthcare infrastructure, is a huge logistical and financial hurdle. The last-mile delivery, the cost of newer drugs, maintaining the cold chain for some medications or diagnostics, these are enormous barriers contributing to why malaria remains so deadly, particularly in vulnerable populations. Equitable access is a major, major issue.
It's clearly crucial to treat infections effectively, but prevention is always better than cure, right? Given the complexity, the mosquito vector, the sneaky parasite, what are the comprehensive prevention strategies that are actually making a difference on the ground?
Comprehensive prevention is absolutely vital, especially because until very recently, widely available, highly effective vaccines have been elusive. Historically and still centrally important is control of the Anopheles mosquito vector. This is often considered the single best approach for prophylaxis or prevention at a population level.
Killing the mosquitoes.
Or reducing their numbers and lifespan, yes. This involves large-scale public health efforts. Things like indoor residual spraying, or IRS, where insecticides are sprayed on the inside walls of houses, killing mosquitoes that rest there after feeding. Also, larval source management, finding and eliminating or treating mosquito breeding sites, like stagnant water.
Okay, vector control. What about personal protection?
Equally important is minimizing human exposure to mosquito bites. On an individual and household level, physical barriers and repellents are crucial. Mosquito nets, especially long-lasting insecticidal nets, LNEs, are incredibly effective.
Bed nets.
Yes. They provide a physical barrier during sleep, which is when the primary malaria-carrying Anopheles mosquitoes are most active, between dusk and dawn, and the insecticide on the net kills or repels mosquitoes that land on it. Distributing these widely has had a massive impact on reducing malaria transmission. Insect repellents containing active ingredients like DE, picaridin, or oil of lemon eucalyptus, when applied properly to exposed skin, offer effective personal protection when outdoors or indoors.
And just covering up.
Absolutely. Simply wearing protective clothing, long-sleeve shirts, long pants, socks, especially during peak biting times, can significantly reduce the amount of exposed skin available for a mosquito to feed on. It's a simple but effective measure. And finally, for individuals traveling from non-endemic areas like North America or Europe to malaria-endemic regions, taking prophylactic anti-malarial medications is key.
Taking pills before you go.
Yes, starting before the trip, taking them consistently during the stay, and continuing for a period after returning. This chemoprophylaxis interrupts the parasite's development in the human host, usually in the liver stage, preventing symptoms from ever appearing. The choice of drug depends on the destination, duration of stay, and individual factors.
It sounds like a truly multi-pronged approach is absolutely essential then. You need the big public health efforts, the nets, the repellents, the pills for travelers, all working together.
Exactly. There's no single silver bullet. It requires a combination of individual actions and large-scale, sustained public health interventions to keep this insidious disease at bay.
But for so many diseases, vaccines are the ultimate game changer. You mentioned they've been elusive for malaria. What's the hope there? Are we finally getting closer to something truly transformative?
Vaccines are indeed a major area of intensive research and, yes, profound hope. The challenge with malaria, unlike, say, measles or polio, where you might target a single stage of a virus, is that malaria vaccine strategies have to contend with that incredibly complex life cycle. So researchers are developing vaccines to target different stages. It's not one size fits all. It's more like a multi-pronged attack strategy.
Attacking different stages, like what?
Well, for instance, there are pre-erythrocytic vaccines. These target the sporozoites, the form injected by the mosquito or the infected liver cells. The aim here is ambitious, to prevent the infection from even establishing itself in the human host in the first place. Block it before it ever reaches the red blood cells and causes symptoms. Stop the invasion at the gate, essentially.
Okay, stop it early. What else?
Then there are blunt stage vaccines. These target the merozoites that burst out of the liver or the infected red blood cells themselves. The goal here isn't necessarily to prevent infection entirely, but rather to reduce disease severity and the clinical illness symptoms. By limiting how much the parasite can multiply in the blood, you mitigate the pathology, prevent severe disease, maybe even reduce deaths.
So less severe illness. Is there a third type?
Yes, and these are fascinating. Transmission-blocking vaccines. These are really different. They target the gametocytes, those sexual stages circulating in the human bloodstream, or the stages that develop inside the mosquito after it takes a blood meal.
So they don't help the person who gets the vaccine directly?
Not directly in terms of preventing their own illness, but the aim is to prevent the infected human from transmitting the parasite to a biting mosquito. If the mosquito ingests antibodies generated by the vaccine along with the gametocytes, it blocks the parasite's sexual reproduction in the mosquito gut. This breaks the transmission cycle in the wider community. It's a vaccine for public health, aiming to stop the spread.
Wow, that's a clever approach. If we connect this to the bigger picture, these different vaccine approaches show scientists attacking the parasite at various vulnerabilities in its complex life cycle, right? Recognizing that maybe one approach alone isn't enough.
Exactly. Given the parasite's remarkable adaptability, a truly effective, perhaps multi-stage vaccine combining different approaches might offer the most robust and comprehensive protection. Hit it early, hit it during the disease stage, and hit its transmission.
It sounds like a really sophisticated strategy, trying to hit the parasite at every turn. But if the strategy is so clear, why has developing a malaria vaccine been such a monumental struggle for so long? Why haven't we had a truly effective one until, well, very recently, with the first rollouts?
There are significant, truly formidable challenges that have plagued malaria vaccine development for decades. It's one of the toughest vaccine targets out there. One major obstacle is that the immune response itself, as we discussed, can sometimes contribute to the disease pathology. So designing a vaccine is tricky. You need to elicit protective immunity without triggering excessive damaging inflammation. It's a fine balance. Another challenge is the sheer efficiency of parasite amplification within the human host. From that initial small number of sporozoites, you get thousands of merozoites from the liver and then potentially billions multiplying in the blood. Even if a vaccine isn't 100% effective at blocking infection, a small number of surviving parasites can still rapidly multiply and cause severe disease. This means a vaccine needs to be incredibly effective, inducing very high levels of immunity to truly prevent illness. And perhaps the biggest, most persistent challenge is the inherent complexity of the Plasmodium parasite itself and its remarkable ability to evade the human immune system through something called significant antigenic variation.
Antigenic variation. It changes its appearance.
Exactly. Imagine trying to hit a moving target that constantly changes its shape, its color, its entire disguise. That's what our immune system, and by extension, a vaccine trying to train the immune system, is up against with Plasmodium. It has thousands of genes, many dedicated to producing surface proteins that interact with our host cells and immune system. It can switch which proteins it displays, effectively becoming invisible to antibodies that targeted the previous version.
Like a master of disguise.
An incredible master of disguise. And it's not just changing its disguise. It's doing it across multiple life stages in different host environments, human liver, human blood, mosquito gut. It creates this incredibly challenging, constantly shifting target that forces our defenses and vaccine developers to play perpetual catch-up. As a result, anti-infection vaccines developed so far have really struggled to elicit immunity that is long-lasting, broadly protective against different strains, and completely sterilizing, unlike vaccines for many other diseases.
Those are indeed some formidable obstacles. It sounds incredibly difficult. But despite these challenges, is there real, tangible progress being made? Or is a highly effective malaria vaccine still just a distant dream?
Despite all those hurdles, there is genuinely promising progress, and the landscape has definitely shifted significantly in recent years. It's no longer a distant dream. The RTS-SSO1 vaccine, often known by its brand name Mosquix, is a landmark achievement. It's the first malaria vaccine ever to be recommended by the World Health Organization for widespread use in children living in areas with moderate to high P falciparum malaria transmission.
The first one ever recommended. How effective is it?
It offers partial protection. Clinical trials showed it prevents about 30-40% of clinical malaria cases and around 30% of severe, life-threatening malaria cases in young children over a 4-year period, requiring multiple doses. Now, that's not perfect, but preventing millions of cases and thousands of deaths is a monumental first step. It's a powerful new tool to be used alongside existing interventions like bed nets.
So a start, but maybe not the final answer.
It's a crucial start, and it paved the way. Blood stage vaccines aiming to reduce disease severity have also shown promise in early trials, being well tolerated and immunogenic, meaning they are safe and provoke an immune response. Research continues intensely on those. And there's now a second WHO-recommended vaccine, R21 Matrix M, developed by Oxford University. It shows similar, perhaps even slightly higher efficacy in trials, and critically, might be cheaper and easier to manufacture at scale, potentially improving access.
2 recommended vaccines now.
Yes. And there is a hopeful projection that this new generation of vaccines, and potentially others in the pipeline, targeting different stages or using different technologies like mRNA, will continue to improve. We might see even more effective malaria vaccines registered and available perhaps within the next 5 years or so, building on the knowledge and successes of these first candidates. This represents a significant breakthrough and offers truly powerful new tools in the global fight against malaria.
The idea that more effective vaccines could be on the horizon, potentially within 5 years, that is incredibly hopeful. Given the persistent challenges and the sheer scale of this problem globally, that would truly be a monumental step forward for human health, complementing all the other efforts. Now, you might be wondering, especially if you're in the dental field, why are we spending so much time on malaria in this deep dive? It's transmitted by mosquitoes, affects the blood and liver. It's not exactly an oral infection, is it? It doesn't directly cause cavities or gum disease.
You're absolutely right to ask that. Malaria is fundamentally a systemic infection, not an oral one. It affects the whole body, originating far from the mouth. And it's important to clarify up front, antiprotozoal agents, the specific drugs used to treat malaria, are generally not prescribed in dentistry. Our sources confirm they don't really discuss antiprotozoal drugs or specific regimens for systemic malaria within a typical dental practice context. So no, it's not about dentists treating malaria in the dental chair. But this raises that important question for our listener. Why would a deep dive into a disease like malaria be so relevant to someone in the dental field? And the answer is really about looking beyond just the teeth and gums. It's about embracing a truly holistic approach to patient care.
Holistic. Seeing the whole picture.
It's exactly. Dental students and professionals are required to possess a fundamental, comprehensive understanding of general and medical microbiology, infectious diseases, and systemic health. This knowledge isn't just academic. It's crucial, not only for understanding how oral infections can potentially affect the rest of the body, but also, importantly, for diagnosing oral signs or symptoms that might be connected to or even be the first manifestation of underlying systemic conditions. And a patient's overall systemic health, including conditions like active malaria or its long-term complications like severe anemia, organ damage, or a compromised immune status, can directly and significantly influence the entire patient treatment plan in dentistry.
How so? Give us an example.
Okay, well, consider a patient with severe anemia resulting from chronic or repeated malaria infections. They might be at a significantly increased risk of excessive bleeding during invasive dental procedures like extractions or surgery. Their ability to heal might also be impaired. Or a patient whose liver or kidney function has been compromised by severe malaria complications that could drastically alter how their body metabolizes local anesthetics or pain medications commonly used in dentistry, requiring dose adjustments or different drug choices. Their overall health status might make them a poor candidate for complex elective procedures until their systemic condition is stabilized.
Okay, so it's about understanding the whole person, not just their mouth, and how these systemic diseases can create complications or present in ways that directly impact dental care decisions. And this brings us back to that really surprising connection we talked about earlier, Burkitt's lymphoma. How does that specific link play out in the dental context? Because that seemed quite direct.
It's a critically important point for dental professionals, and it truly showcases this broader impact of systemic health. Systemic conditions, including malignancies like Burkitt's lymphoma, which, as we discussed, has that strong, albeit indirect, association with endemic malaria, can have direct and often quite striking oral manifestations.
It shows up in the mouth.
Frequently, yes. Burkitt's lymphoma, particularly the endemic form seen in Africa, commonly presents with characteristic rapid swelling, facial asymmetry, or aggressive tumors developing in the jawbones. This can cause teeth to become loose or displaced remarkably quickly. Sometimes these oral signs are the very first indication of this aggressive cancer.
So a dentist might be the first to see it.
Absolutely. A dentist performing a routine exam or seeing a patient for jaw swelling or loose teeth might be the first person to spot these potentially ominous signs. Recognizing them as abnormal and requiring urgent investigation is crucial, and such conditions also significantly influence a patient's capacity or suitability for undergoing routine dental treatment. A patient diagnosed with a rapidly progressing malignancy like Burkitt's needs coordinated care. They might need urgent dental work before starting cancer treatment like chemotherapy or radiation, which often severely impact oral health to eliminate potential sources of infection. Their immune status during cancer therapy becomes a major consideration for absolutely any dental procedure, dictating stringent infection control and careful planning. So dental professionals must be acutely cognizant of these broader medical contexts. They need to understand that oral health is inextricably linked to overall systemic health, and that they often serve as crucial frontline diagnosticians, spotting signs of systemic diseases that might otherwise go unnoticed.
That makes perfect sense. The mouth really isn't an isolated island. It's truly a mirror reflecting the body's overall health. And speaking of medical contexts, even a disease like malaria, which, as we've established, isn't typically transmitted in a dental chair or through routine dental contact, it ironically reinforces the absolute universality and critical importance of rigorous infection control practices in any medical or dental setting, doesn't it?
Absolutely. It's a great point. Adherence to standard infection control precautions, or SICPs, isn't just good practice, it's fundamental. It's legally mandated in all dental practices, regardless of the patient's known health status or the perceived risk of any particular disease they might have. These precautions are based on the core principle of universal precautions.
Meaning, treat everyone as potentially infectious.
Exactly. That foundational concept assumes that all patients are potential carriers of infectious diseases, whether or not they show symptoms or are even aware of their condition. This principle ensures the highest level of protection for both the patients and the entire dental team. So even though malaria itself is typically transmitted by a mosquito vector, not directly via contact, droplets, or aerosols in a dental setting, like, say, COVID or tuberculosis might be, the principle remains. Maintaining strict, consistent infection control protocols for all procedures, for all patients, is essential. This includes meticulous hand hygiene, correct use of personal protective equipment, gloves, masks, eye protection, safe handling and disposal of sharp instruments, and rigorous cleaning, disinfection, and sterilization of all dental equipment and surfaces. Dental practitioners need to be experts in all facets of infection control, not just for practical implementation in their own clinics, but also to effectively guide and train their entire dental team assistants, hygienists, and, importantly, to be able to confidently reassure patients about the safety measures in place and the low risk of cross-infection in a well-managed dental environment.
So it's about having that comprehensive medical understanding, knowing not just what directly impacts the mouth, but how systemic health influences overall patient care, how it affects the safety and planning of dental procedures, and recognizing the ethical responsibility to sometimes spot broader health issues that need referral. It's all connected.
Precisely. That's the essence of holistic patient care, whether you're a dentist, a doctor, or any healthcare professional. Hashtag outro.
Wow, what an incredible deep dive we've had into malaria today. It really feels like we've peeled back so many layers. We journeyed from that ancient, mistaken idea of bad air right through to the microscopic reality of the Plasmodium parasite. We've unraveled its intricate, frankly amazing, two-host life cycle that dance between humans and mosquitoes, a true masterclass in parasitic evolution. We explored its devastating impact on the human body, from those cyclical fevers and chills all the way to severe organ damage, and even that surprising indirect link to Burkitt's lymphoma. Then we moved on to the ingenious ways we diagnose this hidden enemy, from the enduring gold standard of looking under a microscope to advanced molecular techniques like PCR, each offering unique insights into the infection. And finally, we unpacked the multifaceted strategies we use to fight back, the treatments, the constant battle against drug resistance, the crucial prevention methods like bed nets and vector control, and the genuinely hopeful prospects for new and better vaccines finally turning the tide. It really highlighted both the monumental challenges and the promising breakthroughs happening right now. And perhaps most surprisingly, especially for some of you listening, we saw how even a disease seemingly so distant from oral health has these profound implications for dental professionals. It reinforces the critical importance of holistic patient care, the ability to spot potential signs of systemic issues, and the absolute universality of rigorous infection control in every healthcare setting. It really reminds us that truly effective healthcare, whether it's general medicine or specialized dentistry, always has to look at the whole person. So as we've unpacked all these intricate layers of malaria today, explored its history, its biology, its impact, it really leaves us wondering, doesn't it? Given the Plasmodium parasite's incredibly ancient history, its astonishing adaptability, and its proven ability to constantly evolve and evade our defenses, what could be the next evolutionary twist it might take? And how might that challenge our current hard-won efforts to control and eventually eradicate it completely, potentially pushing us into a whole new era of this biological arms race?
Indeed. That's the question that keeps researchers up at night. And it reminds us, I think, that the pursuit of knowledge, whether it's about a single-celled parasite like Plasmodium, the intricacies of the human immune system, or a complex global health strategy, it really is a never-ending deep dive. It's a continuous journey into understanding the profound interconnectedness of life on our planet and the ongoing process of discovery and adaptation, both for the parasite and for us, as we strive together to understand and ultimately overcome these enduring challenges to human health and well-being.